আমরা লাইভে সেলেক্ট সুপ্রিয় চিকিৎসক মন্ডলী, আপনাদের সবাইকে আমাদের টিউবারকুলোসিসের উপরের যে কর্মযজ্ঞ চলছে তাতে স্বাগতম। আমাদের টিউবারকুলোসিসের উপরে আজকে তৃতীয় সেশন এবং এক্সট্রা পালমোনারি টিউবারকুলোসিসের উপরে আজকে দ্বিতীয় সেশন। তো আপনারা সবাই জানেন যে বাংলাদেশের এক্সপেক্টেড টিবির গুরুত্ব যে অপরিসীম, এবং এখনো যে টিবির সাথে সংগ্রাম আমাদের চলছে, এবং এই সংগ্রামে যাতে আমাদের চিকিৎসকরা একটা অস্ত্র পায় সেই হিসাবে আসলে আমাদের এই লেকচার সিরিজের আয়োজন। তো আমাদের সাথে এমন দুজন আছেন, আসলে তাদেরকে নতুন করে পরিচয় করে দেওয়ার খুব একটা কিছু নেই, তারা সবাই আপনাদের কাছে পরিচিত। তারপরে যতটুকু না করলে না, আমাদের আজকের স্পিকার প্রফেসর এম এ হাসান চৌধুরী, ফর্মার প্রফেসর হেড ডিপার্টমেন্ট অফ মেডিসিন, চিটাগাং মেডিকেল কলেজ, অ্যান্ড এক্স ডিরেক্টর বিআইটিআইডি চিটাগাং। এবং আমাদের সাথে চেয়ারপারসন হিসেবে যুক্ত হয়েছেন প্রফেসর এম এ জলিল চৌধুরী, এক্স চেয়ারম্যান ডিপার্টমেন্ট অফ মেডিসিন, বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটি, and ex-honorary secretary BCPS, and আমাদের সাথে আজকে সায়েন্টিফিক পার্টনার হিসেবে আছে এসকে ফার্মাসিউটিক্যালস লিমিটেড। সো উইদাউট ডুইং ফার্দার ডিলে, আমি আমাদের আজকে চেয়ারপারসন প্রফেসর এম এ জলিল চৌধুরী স্যারকে বিনীত অনুরোধ জানাচ্ছি সেশনটি শুরু করার জন্য।
হ্যাঁ, থ্যাংক ইউ ডক্টর ইহসান। না, পরিচয় পর্ব শেষ হয়ে গেছে, পরিচয় দেওয়ার কিছু নাই। আমরা যে তিনজন ছবি দেখা যাচ্ছে এখানে, অ্যাটলিস্ট আমরা সবাইকে চিনি এবং সবাই সবাইকে চিনে। তো টিউবারকুলোসিস ইজ সো ইম্পর্টেন্ট, অলরেডি সবাই জানে যে এটা এমন কোনো অর্গান নাই চুল আর নখ বাদ দিয়া যেখানে নাকি টিবি এফেক্ট করে না। সুতরাং টিবি সবাই জানা উচিত, সব স্পেশালিস্ট টিবি জানা উচিত। এবং এক নম্বর, দুই নম্বর, টিবি একটা মোটামুটি একটা কিউরেবল ডিজিজ, এটা কোনো সন্দেহ নাই। সুতরাং এটা সবাই জানা উচিত। আর আনকিউরেবল যেটা হয়েছে এমডিআর ডিআর, হয়তো পরে বলবে ডক্টর প্রফেসর হাসান, এটাও মানুষের দোষী হয়েছে। সুতরাং সবটা কিন্তু টিভি সব এ টু জেড টিভি সম্বন্ধে জানতে হবে। এবং যিনি বলবেন এটা ঠিক কোনো সন্দেহ নাই যে উনি টিভির ব্যাপারে একটা অভিজ্ঞ লোক। শুধু বই পড়ে মেডিসিন শিখা হয় না, কোনো সন্দেহ নেই, এটা কেউ অস্বীকার করবে না। বই শিখার পরও যে এক্সট্রা যে নলেজ লাগে, সেই নলেজ অলরেডি প্রফেসর হাসানের আছে। টিভি সম্বন্ধে তার অনেক অভিজ্ঞতা অর্জন করছে। সেই অভিজ্ঞতা আলোকে উনি আজকে আমাদের এক্সট্রা প্রবলেম টিভি সম্বন্ধে বলবেন। ভবিষ্যতে আরো একটা সেশন আশা করি নেবেন, যেখানে টিভি বা বাকিগুলো শেষ হবে। তো আমি উইদাউট ডিলে আমি আই রিকোয়েস্ট প্রফেসর এম এ হাসান টু কন্টিনিউ হিজ প্রেজেন্টেশন। প্রফেসর হাসান।
Thank you, sir, for your nice introduction. We are on the third session on tuberculosis, and today's my presentation, my talk in the extrapulmonary TB, part 2. Already we have completed 50% of extrapulmonary tuberculosis, but some important topic is still left. So I try to discuss or focus my presentation on today's presentation on cardiac TB, musculoskeletal TB, renal tuberculosis, liver tuberculosis, genital TB both in male and female, ocular TB, TB in the skin, disseminated TB including the miliary tuberculosis, breast TB, and port site TB, which is a new thing happening in our daily practice now. So let us discuss one by one. First of all, cardiac TB. Pericardial tuberculosis, it is one of the commonest presentation of cardiac TB. Tuberculous pericarditis should be considered in evaluation of patients with pericarditis who do not have a self-limited course. Pericardiocentesis is warranted for routine evaluation of suspected tuberculous pericarditis, but with very special care and monitor support. Tamponine is the absolute indication for pericardiocentesis. So the tuberculosis can affect the pericardium and leads to even cardiac tamponine, the dangerous situation in the heart. In the literature, it is shown that the cardiovascular involvement tuberculosis, pericardium, myocardium, and aorta and its branches, also some intracardiac tuberculoma. But actually directly the coronary disease not related to tuberculosis, but it was found that in different study, there is a 1.76-fold risk of coronary artery disease if there is a active or latent TB. how the bacteria comes to the pericardium. It may be retrograde lymphatic spread from the adjacent lymph node, hematogenous spread, and adjacent spread from the lung, spine, or pleural involvement. So this is the three ways how the tubercular bacilli reach to the pericardium. And there are few stages. I am not going details. One is the, first of all, what is the dry stage? It is called pericardial friction lap and acute pericarditis, then effusive state, then absorptive stage, and final stage is the constrictive pericarditis, where there is no fluid, but there is a severe dysfunction, cardiac dysfunction due to constrictive pericarditis and the calcification. In investigation, we are going to routine investigation, including liver and renal function test, ECG, which is may present with low voltage ECG in case of pericardial effusion. Chest X-ray also cardiomegaly, that is the globular or water bottle heart, and also echocardiogram is important to see the amount of fluid and to differentiate whether it is a constrictive pericarditis or it is cardiac tamponade. Pericardial synthesis, we will, if we do, and we go for cytology, biochemistry, gene expert, and also culture of pericardial fluid for establishment of diagnosis. And these three investigation, if we compare for pericardial effusion, pericarditis, and pericardial calcification, echocardiography is excellent for pericardial effusion and also the functional assessment of constrictive pericarditis. But pericardial inflammation cannot be well defined by the echocardiography. And cardiac CT scan also excellent for pericardial effusion and the pericardial calcification. When there is constrictive pericarditis, you can easily see. Even the chest X-ray can also demarcate the pericardial calcification. And cardiac MRI, which is excellent for effusion, even in early stage of pericarditis, and also the functional assessment in case of constrictive pericarditis. So there is a different role of different investigation in diagnosis, helping the diagnosis of pericardial or cardiac involvement in tuberculosis. If we look, there is a chest X-ray, there is a globular heart, and if you see in the CT scan, there is accumulation of fluid outside the heart and it is well demarcated. And also the pericardial effusion is detected by the echocardiography, and the ECG, there is a electrical alternates in ECG. So these are the investigation, how we can detect the cardiac involvement. Our next topic is the liver tuberculosis. And so liver tuberculosis is sometimes present with pyrexia of unknown origin or liver abscess or hepatomegaly or multiple space occupying lesion. And also as a part of miliary tuberculosis, liver may be involved. And sometimes they may present with granulomatous hepatitis, forming tuberculoma aggregates, nodular hepatitis, nodular involvement in the liver like metastatic or hepatocellular carcinoma, or there may be caseation necrosis, coalesces forming granuloma. There may be ductal involvement of the different hepatic duct, also nodal involvement in the potahepatis causing obstructive jaundice. So these are the, in short, different types of hepatobiliary involvement in tuberculosis. And the spectrum of presentation, if we see in the hepatic involvement, which may be just simple as a pyrexia of unknown origin, hepatomegaly with or without a space occupying lesion, it may be mild icterus or jaundice, abnormal liver function test, especially elevated alkaline phosphatase, and abnormal imaging finding like abscess or a space occupying lesion. And the diagnosis, also routine investigation, as well as the liver function, also some imaging. We have a help in diagnosis, especially the ultrasonography, which can demarcate the nodular lesion, abscess formation, or multiple space occupying lesion. CT scan of the liver and also MRI, mostly they are better than the ultrasonography, with better delineation of the lesion. So also they help in CT-guided FNEC or biopsy of the liver for diagnosis confirmation. And the CLD with tuberculosis, if there is a 9-month regime, we already mentioned in our first presentation, 2 months INS, rifampicin, ethambutol, and 7 months for rifampicin and INS. For total duration is 9 months. Our third topic is the musculoskeletal tuberculosis. Is the one of the commonest form of extrapulmonary tuberculosis, and a spinal TB is 50% of the cases of musculoskeletal tuberculosis, which may be present as a persistent localized back pain or neck pain, or the site of involvement of the vertebral bodies, and also the spinal involvement. And contrast enhancement MRI is the best investigation for suspected spinal tuberculosis. Along with antitubular therapy, sometimes needed the joint immobilization, braces or cast required for better outcome and to prevent complication in case of musculoskeletal tuberculosis. And one of the important book, as the Indian writer, Tuberculosis of the Skeletal System, it is a great book for musculoskeletal tuberculosis by S.M. Tully. And lots of, he has a vast experience on tuberculosis of the skeletal system. And in short, if we see the pathogenesis, how the tuberculosis come to the spine or Boss disease, what we mentioned, it is mostly during primary infection is maybe disseminated in different parts of the body. But when there is a reactivation due to immunosuppression, this spinal focus may be reactivated. And there are 4 types of spinal tuberculosis. Paradiscal, we will show later on what is paradiscal, and central lesion, anterior lesion, and posterior lesion. So the most commonest is the paradiscal spinal lesion. And there is a venous plexus, how this venous plexus helps in aspirator tuberculosis in these cancellous type of vertebral bodies. There are 2 venous plexus. One is the anterior external and the posterior external. Another one is the paravertebral venous plexus, which is a valveless venous plexus. And this helps to spread these tubercular bacilli with the venous and cavity pressure spread to the inferior portion of the vertebra and ultimately involve the intervertebral discs. And it also spread through the anterior longitudinal ligament underlying the anterior ligament to the different vertebral level. That is multivertebral involvement of the spine. And also it may be adjacent or it may be longer distance vertebral may be involvement. And this is the explanation how this is the common type of vertebral, that is the paradiscal, most commonest type, involve the adjacent margin of the 2 consecutive vertebra and reduced intervertebral disc space. This is the lower margin of the vertebra, 2 adjacent vertebra, and there is the erosion of the vertebral margins, lower vertebra, and also the upper margin of the lower vertebra and lower margin of upper vertebra. They are also involved of the discs. Second is the central, it is the type 2 vertebral body involvement. Third is the anterior vertebral part, and fourth is the posterior element, which is really involved. So these are the MRI view, how showing it is the intervertebral disc space reduced and vertebral body collapse. It is in paradiscal, which is most commonest, and there is a central vertebral body involvement, also the anterior portion of the vertebral body involvement, and the posterior portion is involvement. And one of the interesting thing is that the most commonly involved are the lower thoracic vertebra. T10 is the commonest site of the vertebral body, from which the gradually decreased frequency of the vertebral body involvement. It also involves the upper lumbar spine as well as in the cervical spine. And there is sometimes complication formed in the form of paravertebral abscess. How it is formed? There is a granuloma formation, tissue necrosis, and inflammatory response. Ultimately, there is a paraspinal abscess, which may be localized, causing progressive necrosis of the vertebral body and the kyphosis deformity, that is the gibbous. On the other hand, this paraspinal abscess may be dragged down along the tissue plane to the adjacent vertebra under the anterior longitudinal ligaments, and they are spread to the different fascial plane, then in the form of psoas abscess below the inguinal ligament. So in this way, they are causing compression of the spinal cord and sometimes leads to different complication of post disease like paraplegia or paraparesis. Tibia spine should be suspected in any case with constellation of the following features: persistent localized back or neck pain for more than 4 weeks, spinal tenderness on palpation, spinal cord compression with paraplegia, paraparesis, nerve root pain or Cordai-Cuny syndrome, spinal deformity in the form of gibbous, paraspinal muscle wasting, some degree of kyphosis, and generalized constitutive features like fever, weight loss, and night pain, inability to walk or caution in the gait. Also, use of hand support to head or trunk can be seen in case of children. So we should be very careful regarding the spinal manifestation of tuberculosis because if not timely intervened or they are not diagnosed early, there may be long-time sequelae can occur, in the neurological sequelae can occur. And mechanism of paraplegia or tetraplegia, academic interest for our postgraduate training, how it can cause paraplegia in early onset paraplegia due to mechanical pressure by the tuberculous debris, sequestrum, disc, abscess, subluxation, dislocation, tuberculous granuloma, tuberculous myelitis, spinal artery thrombosis, tuberculous arachnoiditis, and also late onset paraplegia can occur due to transection of spinal cord by bony bridge or fibrosis, pachymeningitis. So different ways there may be paraplegia or tetraplegia when it is involved above the C5 level. And there is a classification of POTS paraplegia. Tully and Kumar and Indian writers, they give paraplegia. I am not going details. The paraplegia of extension and paraplegia of flexion and different grading. And at any level, we may get the patient. So how investigate? Simple X-ray spine, we may get sometimes the collapsed vertebral body or CT spine, MRI of the spine, which is the best way of diagnosis, CT-guided FNEC of the abscess for cytology, F-based and gene expert, and culture of the for tuberculous bacilli, or even we can go for open biopsy for histopathological examination and immunohistochemistry or PCR method detection. Other also needed the chest X-ray for exclusion of pulmonary tuberculosis, tuberculin test, and routine investigations. And also this is the needle CT-guided, how we can do the CT-guided FNEC, minimally invasive, or it may be go for direct open biopsy, sometimes is needed for confirmation. And academic interest for the trainee doctors, there is some differentiating point, tuberculous spondylitis and pyogenic spondylitis. In case of tuberculous spondylitis, the spinal abscess is predominant, but pyogenic, there is a less paraspinal abscess. And abscess wall is thin and smooth in case of tuberculous, but it is pyogenic thick. Post-contrast margin well-defined in spondylitis. Also, the multiple vertebral involvement usually seen as spondylitis, tuberculous spondylitis, but none more than 2 in adjacent between pyogenic. So in this way, we can differentiate by radiological and the history acute disease and also the chronic or subacute form of in tuberculosis. And also the vertebral disc is more severely affected in case of pyogenic spondylitis. Another important differentiating point from tuberculous spondylitis from the brucellosis, which is not uncommon in our country, but sometimes it may be confusion with brucellosis spondylitis, chronic form of brucellosis involving the vertebral body. I am not going details, it is written nicely in the books. But most important thing, we have to differentiate spondylolischisis versus metastatic spinal disease. It is very important for us. Sometimes the metastasis, bony disease is confused with tuberculosis or other infection. This space is usually narrowed or reduced in case of spondylodiscitis. but it is not intact always. In case of metastasis, osteoporosis, it is usually intact. Vertebral end plate, that is the inferior margin of the superior vertebra, there will be eroded, and it is the paradiscal involvement of the tuberculosis. But in case of metastasis, the vertebral erosion is absent. And lytic lesion in the vertebra is usually commonly present in metastatic bone disease. Paravertebral soft tissue usually present more in tuberculosis or spondylolischisis. And posterior elements of the vertebral body, that is the pedicle, which is usually commonly destroyed by the metastatic bone disease. And there are a few examples of metastatic bone disease. One is the lung, thyroid, kidney, and colon. They are always causing the osteolytic lesion, but prostate is always causing osteoblastic, and the breast carcinoma metastatic can cause both osteolytic and osteoblastic lesion in case of bone disease. This is the classical example of gibbous formation, angular deformity of the spine due to collapse of the thoracolumbar region of a patient of a spinal tuberculosis. You can see easily destroyed vertebral body and reduced disc space. These are the intermediate disc intake, but here in these two vertebrae, it is destroyed. So it is destruction, collapse, and angulation of the vertebral column, and there is also some edematous changes in the T2 image of a spinal MRI. And it is early stage of POTS disease. Sometimes it may lead to compression of the spine, the spinal cord. This is the metastatic features, how we can see the collapse of the vertebral body, but disc space are intact, and there is a bony edema, and also there is the spinal cord edematous in case of metastatic bone disease. These are the diagrammatic picture, how it is compressing the spinal cord. So it is a pathological fracture caused by metastatic breast cancer. So in this way, MRI is very helpful to differentiate easily from spondylolischisis from the metastatic bone disease. These are the one of the paravertebral abscess you can see in the dorsal region, in the paravertebral abscess, and suspected case of tuberculosis. But in the sagittal view, you will not see any vertebral involvement, but there is in the sagittal view, you'll see in the there's a paravertebral abscess of tuberculosis. So this is another clearly visible POTS disease, paravertebral abscess. This is another vertebral body involvement, two or more vertebral body involvement. These are the destroyed intravertebral discs and also the vertebral bodies in tuberculosis. There is a big paravertebral paraspinal abscess. This is a plain X-ray showing the destruction of the L4 vertebrae, and also as well as there is a chest X-ray showing the bilateral involvement of the tuberculosis. So chest X-ray we should always done during extrapulmonary tuberculosis diagnosis. Sometimes it is very helpful and significant for diagnosis. This is another causing the compression of the spinal cord due to collapse of the vertebral body and the spinal abscess. This is psoas abscess formed in case of lumbar spine and tuberculosis. So these are the various examples how the vertebral body involvement and causing the spinal cord involvement and tuberculosis of the spine. What are the complications can occur? Paraplegia, cold abscess or paraspinal abscess, spinal deformity, chronic sinus formation, secondary infection, even the long-standing cases, amyloidosis. So these are the various complications. Most dangerous is the neurological complication. So sometimes there is a surgical intervention is needed in case of a spinal tuberculosis, along with anti-tubercular therapy. Patient with what are the indication? One is the spinal disease with advanced neurological deficit. Patient with a spinal disease worsening neurological deficit, progressing while on patient on anti-TB therapy. If there is a despite anti-TB therapy, there is a progressive lesion. and patient with a spinal disease with kyphosis more than 40 degree, and patient also along with gastrowal cold sepsis. So these are the few indication for surgical indication for spinal tuberculosis, but most of the patient is response to the conservative treatment and anti-tubercular therapy. And more than 50% also involvement, there is the joints, mostly weight-bearing joints. One of the important joint involvement of the hip joint. I am not going details. There may be swelling, pain, and difficulty in walking when there is hip joint involvement. And also there may be narrowing of the joint space and also erosion. Ultimately, advanced stage, there may be subluxation or dislocation. Second commonest is the knee joint tuberculosis. There may be bogie synovial swelling or on examination, effusion. So we can do the synovial biopsy as long as with fluid analysis for tuberculosis. One important term used sometimes, tuberculous rheumatism or Ponson's arthritis, is an acute symmetric polyarthritis involving large and small joints associated with active extrapulmonary pulmonary miliary tuberculosis. Actually, this is an inflammation of involved joint, no evidence of active TB. Ponson's disease is really rare and the pathogen is unclear. It is probably immune-mediated. HEB co-infection is a risk factor. The arthritis strikingly resolved with a few weeks of initiation of anti-tubercular therapy with no joint destruction or residual effect. Other joint as well as the elbow, shoulder, ankle, foot, wrist, and hand joint may be also affected in tuberculosis. So these are the example of wrist joint involvement, also the hip joint involvement. There is a narrowing, fusion, and destroyed head of the hip of the tuberculosis involvement, and also MRI is a very good investigation for dissection of tuberculosis. Sometimes we have to need for biopsy or confirmation. Our next topic is the urinary tuberculosis or renal tuberculosis. It is not uncommon. It is commonly affected in adult males, and estimated prevalence of urogenital tuberculosis in India, it was found that 4% of all population of extrapulmonary tuberculosis, but in our country, I don't know exactly what is the prevalence. Diagnosis is made by the history examination in urine routine examination, usually a sterile pyuria or hematuria. Even the centrifuged urine may be used for gene expert. Also urine culture for 3 days culture in Lowenstein Janssen media or MGIT, and some imaging also helpful by ultrasonography or intravenous urography, which is commonly practiced previously. Nowadays, it is contrast enhancement, CT scan or MR urography is used commonly to diagnose urinary tuberculosis. Medical management is the mainstay of therapy in urinary tuberculosis. Sometimes if there is obstructive uropathy, surgical reconstructive therapy may be needed for ureteral stricture or constricted bladder. And these are the picture shows there is a swelling in the ultrasonic imaging, nodule in the outer surface. There is a biopsy or macroscopic tissue after nephrectomy, and there is some epithelial granuloma, and also shows even the bacilli may be found in acid-fast bacilli may be found in the tissue. How the presentation of renal tuberculosis, commonly it is dysuria, hematuria, sterile pyuria is the striking features, recurrent UTI, and constitutional features like fever and weight loss. Also, there may be uncommon presentation like interstitial nephritis, glomerulopathy, and amyloidosis. There is some renal classification of renal TB stage 1, 2, 3, and 4. And sometimes there may be autonephrectomy occur, that is called party kidney, radiologically called. Investigation, most of the investigation is the urine analysis, but the threshold for urine for acid-fast bacilli is 5,000 organism per ml, and it has sensitivity is less and specificity is more, but gene expert also important for centrifuged urine, and FB culture, especially MGIT or solid culture media for 3 samples is needed. X-ray KOB region, also ultrasonography, IBO previously practiced, now CT urography with contrast assessment, MRI urography, or erythrocystoscopy, sometimes helpful directly to take the biopsy. Febrile pyruvia, when there is a more than 10 WBC, but absence of pneumotic symptoms and culture isolate, no pathogen. There may be other causes of febrile pyruvia, like tuberculosis, malignancy, stone, vasculitis, and chlamydia atypical organism causing the infections like chlamydia, uroplasma, uretem, etc., fungus, interstitial nephritis. So we have to also exclude other causes of febrile pyruvia. And there is a many characteristic finding in IBO, party kidney, ball on tree sign, phantom calyx, daisy flower kidney, sawtooth appearance, carking, pipe stem ureter. These terms actually used when we are practicing IBO. I am not going details, but the common ultrasonography finding, we can see the focal calcification or cortical calcification. In the kidney, there may be progressive papillary extraction, distorted parenchyma, hydronephrosis, mucosal thickening or ureter involvement, and there is a small fibrotic thick wall bladder, pyonephrosis. End-stage disease, there may be a small shrunken kidney, pepper-thin cortex, dystrophic calcification, important finding in ultrasonography. These are the ultrasonography gross hydronephrotic changes with non-dilated renal pelvis on ultrasonography. These are the various forms of obstructive uropathy seen in case of IBO. I am not an hydroureter, and some parts you will not see there is a constriction of the ureter. The ureter is not visible in the lower part. Also, there is some kinking of the ureter, stricture, and on the right side there is a dilatation and pelvic system dilatation. Also, there is a in tuberculosis, pelvic CL dilatation, ureteric stricture. So that the major findings, even advanced stage, we can see a small non-functioning right kidney containing calcific fibrosis. It is autonephrectomy. And also there is a CT finding, various type of CT finding. I am not going details, already almost similar type of finding like IBO. And these are the findings in CT, renal abscess formation, and also there is some lobular calcification in the kidneys. Now the genital tuberculosis, male genital tuberculosis also can occur any part of the genitalia, scrotum, testes. Most common is the epididymis, and the urethra also can be affected by a stricture, penile ulceration, swelling or purulent discharge, epididymis, which is the most commonest, and testicular involvement, also prostatic abscess, seminal vesicle also can be involved in case of male genital tuberculosis. These are the various pictures shows testicular involvement and also testicular parenchymal lesion in case of ultrasonography and biopsy. Also the large abscess in case of HIV within the prostate and seminal vesicle involvement. These are the penile tuberculosis in the form ulceration and some nodular lesion. Also, there is a prostatic tuberculosis involving fistulogram showing destruction and erythrocutaneous fistula. Female genital tuberculosis is most common, and mostly they are present with infertility, and they are most common in premenopausal women. And so adequate history, examination, and endometrial aspiration for FB, mycobacterial tuberculosis culture, and gene expert and histology is most common by hysteroscopy or histosalpingography, or even the laparoscopic and laparoscopic biopsy. So mostly the treatment is the medical treatment, and sometimes there is maybe needed surgical intervention when there is a biosulfings. And fallopian tube is commonly affected, causing the endosalpingitis or exosalpingitis. Also, they are causing infertility, and tubal block, bilateral tubal block can occur. There may be endometrial tuberculosis and also causing some abnormal uterine function. Ovary also can involve, cervix is involved less commonly. Even the vulva vagina can be involved in the form of growth and ulceration and fistula. So there are various presentations starting from the swelling, ulcer, discharge, erosion, nodule, uterus synechia, Asthma syndrome, and Asherman syndrome, tubal blockage, salpingitis, hydrosalpinx and pysalpinx, ophuritis, tube ovarian mass. It is one of the common presentation. And also important for a gynecological examination for exclusion of other lesion, mass of the abdomen, ascites, along with abdominal tuberculosis. There may be uterine enlargement, pyometra, adnexal masses, tube ovarian masses, and there may be fullness and tenderness of the post of Douglas. So DNC may be done for cytology and biopsy, laparoscopic and biopsy, and histosalpingography, even the MRI or CT of the pelvis. And there may be different differential diagnoses according to involvement of the different structure of the female genital tuberculosis. And also these are some visual laparoscopic view of bilateral tubal beaded tubes embedded with tubercles. So this is a cutaneous caseous necrosis and bilateral tube ovarian mass, fallopian tube started with tubercle, and the epidural granuloma seen in case of endometritis. So these are the other histosalpingogram finding, diverticular outpushing of the anterior tube in case of miliary shadow, in case of fallopian tube, and this also laparoscope view of the dense adhesion between uterus and adnexa, and these are the laparoscope view showing blocked dilated tube and dense omental adhesion. These are one of my gynecology colleague given this picture. He has done infertility and tube ovarian mass, and so you can see very beautiful granular appearance of the peritoneum started tubercle with laparoscopic view. And this is two cases. This is courtesy by Dr. Reshma Sharmin, and another case also I have found few days back with tubercular salpingophuritis that's also presented with tuberculosis in the infertility and tube ovarian masses. These are the another two cases of histologically proved tube ovarian masses. And ocular TB, not eye is spared from the tuberculosis. Sometimes it is the posterior uveitis is the commonest presentation. Also, as well as the drugs also can involve the drug side effects, toxicity can cause the tuberculous destruction, eye involvement, and also there may be granulomatous other disease